are there any, basic first line treatment options that we should be familiar with as general practitioners in terms of what they are, but also any important side effects from them?
Yeah, absolutely. And in fact, I'll step back and start with the MGUS itself because one of the, as I was going through my training, one thing I always wanted to know was what is the natural history of every disease? Like, I really needed to know that because otherwise I wouldn't be able to wrap myself about what is going to happen to this patient most of the time. So if you take MGUS, all MGUSs together, there's a 1% per year risk of progression to myeloma. But because patients are not young and healthy when they're diagnosed, most of them are 70, 75 when the MGUS is diagnosed. When you adjust for competing causes of death, if you take 1,000 people with MGUS, only 100 ever get myeloma or related disorder, even over a 20, 30-year period. So 90% actually die of other causes without progression, which means that they should really be taken care of as any other general internal medicine patient with monitoring their diabetes, their hypertension, their colon probe screening and everything, because that's what's going to be their likely problem, not the MGUS. So that's the natural history of MGUS. And if it's a low risk MGUS, then the lifetime risk is not even 10%. It'll probably be like 2%. Then you come to smoldering. Smoldering myeloma is this in between stage where I want to follow the patient more closely because they have a 10% per year chance of progression. In 5 years, half the patients have progressed, and they've progressed with crab features or something like that. So we want to watch them every 3 to 4 months. And what the internist should know is that some of us are beginning to treat the highest risk smoldering patients now in an attempt to prevent this inevitable progression or at least delay this progression. So the high risk smoldering myeloma population, some of you might see patients getting a drug called Revlimid or Lenalidomide or Daratumumab on clinical trials, trying to see if we can delay the progression. For patients with full-blown symptomatic myeloma, when I started in the field, the median overall survival was 2 to 3 years. Right now, for people age less than 65 with multiple myeloma, the median survival is in excess of 13 years if patients have no high-risk cytogenetics. If they have high-risk cytogenetics, it's still more than 8 years. So people should know that a myeloma patient is now going to live for years and years. Even older patients live 7, 8 years or longer now. And so the prognosis improved considerably. And the drugs we use are kind of unique. We don't use these in other cancers, so it might be worthwhile for people to know. Out of pure serendipity, we found that thalidomide works in myeloma. And so its derivatives, lenalidomide and pomalidomide, they go by the trade names of Revlimid and Pomalyst. Those are very commonly used. And because patients stay on them long term, you will see patients taking lenalidomide for like years at a time. Like, as long as it's working, we keep giving it. So the internist should know about this drug. They should also know about it because it is extremely expensive, like $15,000 to $17,000 a month, and it's the number two cost for Medicare for drug spending overall of all the drugs in the world. So this is something internists should know. The other class of drugs that we use is proteasome inhibitors, particularly Bortezomib or Velcade and carfilzomib by Kyprolis. Proteasome inhibition is a Nobel Prize-winning discovery. It's the garbage disposal system in the cell. If you inhibit the proteasome, then the cell dies. We thought it'll work in all cancers, but it works mainly in myeloma. So we use it, and between Bortezomib and lenalidomide, that's two drugs, at least two classes of drugs that they should know about. The final one will be Daratumumab, which I predict will become the next rituximab in the next 5-10 years. We use rituximab starting with lymphoma, but now we use it for everything, autoimmune disorder, autoimmune hemolytic anemia, because it kills the B cells. But B cells don't make antibodies, plasma cells do, and plasma cells don't have CD20. So Daratumumab targets the actual plasma cell with anti-CD38 and very quickly drops the antibody production. So we are starting to use Daratumumab. We use it in myeloma a lot, but we are using it more and more in trials and even in clinical settings to treat patients with a variety of non-malignant autoimmune disorders. As far as side effects, lenalidomide and thalidomide, both of them cause peripheral neuropathy, as well as they increase the risk for blood clots. So you'll see all our patients are on aspirin or blood thinners. And proteasome inhibitors, particularly Bortezomib, causes a peripheral neuropathy as well. And so that's also something internists should be aware of.